Like this is a later version of an advancement where you do not have to do an open abdominal surgery, but you are going through the internal jugular vein, and this procedure is called as TIPS, and from internal jugular vein to the end, patient's hepatic vein will be obtained or accessed, and then through there will be a gel foam technique. By then there will be filling up of the vessel, and then there is a reduction in the portal pressure. As I said, TIPS is being done, and you need to make sure that when the procedure is ongoing, you don't want to have a prolonged bleeding or an abnormal coagulation problem. So you need to cover the patient with good antibiotic for secondary infections, and also you need to give fresh frozen plasma. And of course you have portosystemic shunt surgery too. As I said, in medically, even before the patient has been approached to all these other measures, as I mentioned, they're going to start them on propranolol beta blocker 80 to 160 milligram per day in divided doses with an escalation slowly. Of course, if there is no absolute contraindication, you could use this. And as I said, prophylaxis of initial varicose bleeding should be undertaken, because we know varicose bleed is dangerous. This is a chart, I hope you could see it clearly. So where there is a flow chart of how you initially evaluate the patient's body volume status, blood loss and fluid replacement, which has to be done. And then only once the patient is stabilized and confirmation of the diagnosis, then you will go through all the medications which I mentioned earlier, or the form of mode of therapy. We'll continue. Ascites is a very important complication which also increases the morbidity and mortality in patients with cirrhosis. We will have accumulation of excessive fluid in the free peritoneum, you all know that. And of all the causes of ascites, cirrhosis is the most common one, which produces transudative majority. It could become exudative whenever there is a patient's body immunity reduced and having infection. Causes of ascites have been mentioned. Many causes are there. This slide will be useful for you, because you are going to differentiate, or you are going to analyze and in your patient and then come to a conclusion, because there are a lot of, if you see the slide, majority of the causes are liver causes. Then coming to the pathogenesis, here I would like to tell you in summary. Please remember, whenever there is an increased portal pressure, it causes sodium and water retention in the body and localization of the fluid predominantly to the peritoneum. And this occurs, as I said, there is a high venous pressure, especially in the mesenteric circulation, and in 3 types of theories have been proposed in ascites due to portal hypertension. They are underfilling theory, overflow theory, and peripheral arterial vasodilatation theory. So you could see this multiple factorial depiction in circles, how it's going on and how the patient is developing the ascites. Now, as we said, fullness of the abdomen with fullness of the flanks, shifting dullness, fluid thrill, this will be there. And patient will have an abnormal umbilical shape and sometimes position, and striae in the abdomen will be there. Hernia due to increased chronic abdominal pressure. Divarication of the rectus abdominae muscles will be there, and patient may also have meralgia paresthetica and also scrotal edema. And in fact, very surprisingly, we find something called as hepatic hydrothorax, where 10% of the patients can have pleural effusion. Now coming to the investigations, of all the investigations, ultrasound abdomen is very important, and look particularly for the hepatobiliary system. And abdominal paracentesis has to be done both as diagnostic and also to look into the complications of cirrhosis. And we also exclude other conditions, coexisting conditions in the abdomen like amylase, etc. And that's how we get a ultimate value of a transudative ascites, and that is always a cardinal manifestation for portal hypertension. And here ascites, we have said this is again to make you look into quickly as soon as you get an ascitic fluid for analysis. You should know if it's cirrhosis, it's going to have an appearance like this, transitive, and malignant disease or any infectious disease may produce turbid or cloudy, we call it, and then biliary communication is there, means patient will have a very bile stained fluid. Okay, now we move on to the treatment of ascites. A thorough search for the precipitating factor in recent onset or of worsening ascites in chronic cases, example whether there is an excess salt intake onwards, non-compliance or any superimposed infection is there in the patient, or worsening of the liver functions, or progression into hepatocellular carcinoma and portal vein thrombosis need to be looked into. Then most important thing is the sodium and water restriction, that's very important, and that itself leads to a good amount of diuresis, you need to know that. So that's why you refer the patient to a dietitian for the proper diet for chronic liver disease. Then restriction of salt is too low, we call it as low salt, that's almost around 80 millimoles per day. That means you just don't have to add any extra salt at all. But sometimes there is a prescription of even up to 40 millimoles, that's too difficult to achieve for the patient sometimes, and fluid restriction should be 0.5 to 1 liter per day. And you all know that the diuretics which are used, the spironolactone, which is also behaving like an aldosterone antagonist, should be used. But please remember that because we are giving a long-term therapy and we escalate the dose up to 400 milligram, do watch the patient for side effects like painful gynecomastia and hyperkalemia, because it's a potassium-sparing diuretic. Majority of the practitioners also add furosemide, which is very potent loop diuretic, like 40 to 80 milligram per day will be required in the initial stages. Later on you can combine, and always as a dictum, always look into the side effect profile of your patient. It's unique for your patient, and other diuretics have also been tried. And along with diuretics, please give bed rest to the patient. And now coming to the abdominal paracentesis, usually we need to do large volume paracentesis of 3 to 5 liters over 1 to 2 hours, and this will immediately relieve a lot of cardiorespiratory distress. And always supplement colloid or human albumin. And now we come to other treatment, surgical mode of treatment. I would not like to go with this, I already mentioned, but leave-in shunt is one and TIPS is another one. Now complications and prognosis of ascites as such, because now we are going to give a holistic look into ascites. You did not confine it to cirrhosis. So look into all the complications, whether the patient goes into any infectious problem or renal failure. And prognosis, when a patient has ascites and cirrhosis, 10 to 20% of them survive for 5 years. It's best determined by the underlying liver function test which you monitor throughout the course of the illness. Now spontaneous bacterial peritonitis is a very important complication which may take away the patient's life. As I said, there will be a sudden onset of diffuse abdominal pain, fever, and patient will have tenderness, and there will be absent bowel sounds, and there will be fever, and you suddenly see the amount of fluid has increased, abdominal distension has increased. So patient will also go into hepatic encephalopathy and fever because he has the underlying infection in the peritoneum. Now sources of infection immediately you may not be able to determine, but you need to always send the culture, and the commonest organism of the ascitic fluid culture is E. coli, and other organisms like enteric gram-negative organisms will also be there. And you need to do paracentesis and make a diagnostic test for the polymorphonuclear neutrophils, that is more than 250 cells are there per cubic centimeter, means then that is diagnostic. And they also send the blood culture for the septicemia. And broad spectrum antibiotics need to be used, ceftoxime, and metronidazole can be used per rectally or oral or IV. And at times we need to put the patient on prophylaxis, norfloxacin oral tablet to prevent recurrence. Now coagulopathy is a very important complication where you look into the diminished coagulation factors, because liver is the factory which is synthesizing them, and now we do not have them. So that's why all the vitamin K dependent factors except factor 5, all of them, 5, 7, 9, 10 is there, and prothrombin factor. So all these are going to be affected. There will be a decreased synthesis of them, and thrombocytopenia can happen because of hypersplenism. Now, hepatic encephalopathy is a neuropsychiatric syndrome characterized by mental changes progressing from confusion, stupor to coma. So this also indicates an underlying severe hepatic impairment. It is seen in all the patients with chronic liver disease or cirrhosis, as we have seen now, and can also be seen in acute liver cell failure. Now, what are the two main factors which we are looking into in the etiology? The hepatic failure and the portosystemic shunting of blood. Most important thing what I want you students to remember, the pathogenesis of hepatic encephalopathy has evolved now. People have found out much more than the nitrogenous substances. Ammonia and GABA is very important here. Now, factors precipitating hepatic encephalopathy, these are very important, and you need to keenly look into these factors when a cirrhotic gets admitted in your wards, like uremia, drugs like sedatives, tranquilizers, or even hepatotoxic drugs, hypnotics, upper GI bleed, excessive dietary protein intake, meat, etc., constipation, paracentesis, electrolyte imbalance like hypokalemia, then infection, portosystemic shunts, or surgical or spontaneously also it can occur, and trauma including surgery. Now, clinical features, as I said, if the patient is having a slow onset of symptoms, you see a change in the intellect, personality, emotions and consciousness with or without neurological signs. Early features may be mild, but later on patient will go into lot of complications with the speech abnormality, etc., and stupor and up to coma. Now, the differential diagnosis, I made a list, we just can go through later. Now, the investigations is mainly by clinical, but you need to know that EEG is very specific at times to look into the delta wave progression, and arterial ammonia level is very important, it will be elevated. You have to identify, treat and remove the precipitating factor. That's the key thing for management or treatment of hepatic encephalopathy. Always reduce and eliminate the protein intake. Glucose should be given to the patient and suppress the neurotoxin. Okay, dear students, herewith we conclude, and we have a take-home message that we need to have a broad outlook on cirrhosis of liver with the following headings like etiology, pathogenesis, clinical features, complications, investigations and treatment. And with this, I would like to thank all of you for your kind attention and your raptured eagerness to learn more about cirrhosis of liver and portal hypertension. Thank you. Thank you. Thank you.